Hi, everybody. Thanks so much for joining us. Sorry for the few-minute delay getting online here. But we're really excited to be with you today for our inaugural National Scoliosis Clinic webinar. By way of introduction, my name is Mike Gardner. I'm an orthopedic surgeon here at Stanford, and I'm thrilled to be joined today by Dr. John Vorhies, who's also an orthopedic surgeon here at Stanford. As a very brief overview, we've recognized some serious flaws in the healthcare system as it relates to scoliosis. And this really applies to all aspects and components of a patient's journey through scoliosis, beginning with initial screening and the accuracy of that process, access to expert scoliosis care once a diagnosis is made, the methods of ongoing monitoring for scoliosis, delivery of effective educational information to families and patients, the ability of parents and patients to ask live questions of various types of providers, doctors, brace makers, therapists, etc. So for today on the agenda, we're going to be covering a brief overview of what is scoliosis. We'll dive a little deeper into some of what the current problems are. We'll also touch on some exciting new technologies and some new research being done by Dr. Vorhies and his team here at Stanford around assessing the severity of scoliosis without radiation. And then finally, we'll review how myself and Dr. Vorhies and a team of other doctors have designed the National Scoliosis Clinic to really revolutionize scoliosis care by putting the patient at the center of the team and providing treatment programs to hopefully avoid surgery and provide peace of mind. At the end, and actually once or twice during the presentation, we'll have time for some questions. So please add any questions to the Q&A section through the Zoom, and we'll get to them throughout. So we'll start first. I'd like to introduce you to Dr. John Vorhies. John, welcome, and thank you again for joining us. Maybe we'll start with just a brief overview of your training path and how you came to be in your current practice, and then as it relates to your current experience with scoliosis.
Sounds good. Thanks, Mike. So I'm John Vorhies. I'm a pediatric orthopedic surgeon here at Stanford. And so being a pediatric orthopedic surgeon means that I did a residency training in orthopedic surgery. I did that here at Stanford. And then I went and did a fellowship after that, 5 years as a resident to really learn how to take better care of children. And a big focus of that fellowship was care of patients with scoliosis. I did that at Texas Scottish Rite Hospital in Dallas. And then several years ago, I came back to set up my practice here at Stanford. And here at Stanford, I take care of mostly patients with scoliosis and problems with their spine. So through that experience, I got to see different ways that people interact with the medical system, and I got to learn about different challenges that patients and families come up against when they learn about a scoliosis diagnosis and try to navigate different avenues for how to treat it. And that, has led me to collaborate with you and with NSC to try to come up with some different solutions, maybe outside of the standard pathways where people obtain care, to try to help people navigate the system and find the best care for their children.
Awesome. Thanks so much. Well, I'm certainly excited to tap into some of your knowledge today. So maybe we'll get to kind of a brief overview of scoliosis from your perspective and how you explain it to patients and some of the issues around it.
Sounds good. Okay, can you see my slides all right there?
Yes.
Excellent. So thanks. I'd like to start maybe, I know we have a lot of people on this webinar from different backgrounds, and some people might have varying knowledge about scoliosis and different understandings of how it's cared for. So to just maybe get us all on the same page, I prepared a little intro of scoliosis. It's actually modified from a talk that I give to medical students. Part of my job here at Stanford is educating residents and medical students, and so this is the same stuff that I teach them about how scoliosis works. Okay. So scoliosis is a three-dimensional spinal curvature. And so here I've given an example of a 2D X-ray, which is the main historical way that we as orthopedic surgeons and doctors have quantified scoliosis. But really it is a 3D issue. We just define it in 2 dimensions. So this is an example of how we measure the Cobb angle. And so the angle of the spinal deformity as defined by the Cobb angle is how we really define the severity of scoliosis, and then how we organize it in terms of how to treat these patients. It's also how we really quantify how risky it is for scoliosis to actually affect the life of a patient who has it. So this is a diagram of how we measure it. We basically start from the bottom of this X-ray, which shows a curved spine. We look at how tilted the vertebrae are. We pick the most tilted vertebra, we draw a line at the bottom of it. And then we sort of march up until we find a tilted vertebra in the other direction and draw a line there. And then the computer extends these lines out into space and measures the angle between them, and that's called the Cobb angle. And so I do this, other orthopedic surgeons do this, radiologists do this, and that's how we define the severity of scoliosis. Now, it's not an exact measurement. There are some error bars around it. So it's been defined that, the same trained observer looking at the same X-ray on different days might measure it 5 or 6 degrees different. So you can't exactly hang your hat on the number, but understand that it gives you a good idea of how big a curvature is. So why is scoliosis an issue? So scoliosis for many patients is actually not that big of an issue. So a lot of the patients that I see, in fact, the vast majority of the patients that I see are not going to have a big impact on their quality of life because of a spinal curvature. So a small curve doesn't really increase your risk for having back problems in the future. And it usually doesn't affect kids' life very much when they first discover it. Some patients can have back pain and some patients can have scoliosis, and sometimes those populations overlap. But most patients with a small scoliosis don't actually have any disability or pain directly as a result of the scoliosis. But we do worry about it because as a child grows, a small scoliosis can sometimes turn into a larger scoliosis, and larger curves can cause problems. So larger curves can progress even after growth is done. They can cause back pain. They can cause issues with pulmonary lung function in very severe cases. And they can affect your posture and your balance. So here I have a picture of a patient with a moderate curve here on the left, and this is a child that has an example of a child that has a lot of growth remaining. And then what that might become later on in life, this is a patient who's an adult who has developed a worsening curve that's stiffened, and this is in the size range that might affect their quality of life. So here's an example of a typical patient with adolescent idiopathic scoliosis. So it's an abnormal rotation curvature of the spine, and there are some typical characteristics that we see when we look at a kid who has scoliosis. They might have a little bit of a shift in their trunk, a little bit of a change in the shape of their rib cage and symmetry. And typically it happens in people who don't have anything else wrong with them. They're usually normal, healthy kids. And in most cases, as the name implies, idiopathic means we don't have a specifically identified cause. So we believe that it is probably genetically related, but it's not like one gene that we can test for. It's probably an interaction of many different genes that come together that program your child's spine to grow with a curve. It's not their fault. It's not anything you did or didn't do, or it's not anything that the kid did or didn't do. It was the genetic programming for doing this was already in them. And even though they were born with a straight spine, as they hit their adolescent growth spurt, sometimes that rapid growth causes things to grow askew. So how do people typically come to me as an orthopedic surgeon? Well, it can happen through different ways. So the typical patient is screened every year by their primary care provider, if that's a pediatrician or a nurse practitioner or a physician assistant, or in some cases screening is done at schools by nurses. And so patients will be screened, and somebody will notice an asymmetry, and sometimes that asymmetry is noticed even by a parent or by the patient themselves. And then they're sent to a pediatrician maybe who can evaluate them more thoroughly. And then the pediatrician can use different tools. Maybe they just visually examine a kid. Maybe they actually use use this device here called a scoliometer, which measures kind of it's like a carpenter's level that measures the angle of a tilt that you see in a child when they bend over on their back. And then they might have some criteria to send the patient to me if it's a more severe curve. And then I might follow that patient, determine if they need any treatment or if they need continued observation, which we typically do as a standard of care with x-rays, because that's how most of our treatment paradigms are designed. And so just to give you an idea of how I use the Cobb angle in decision-making, these are sort of generally accepted national guidelines that describe how we treat patients. There are exceptions to these, of course, but most patients we treat based on these categories of curvature. So under 10 degrees of Cobb angle is normal. You can get that from just a postural lean. 10 to 20 degrees is mild scoliosis. So in some cases, mild scoliosis doesn't progress at all. So we usually recommend just monitoring these patients and not initiating any specific treatment. If you have a moderate scoliosis, which is defined as 20 to 45 degrees, or you have somebody with documented progression and they're skeletally immature, which means they have a lot of growth remaining, that's the window of treatment for a brace. And so the brace is by far the most effective non-operative treatment that we have. And then if you get above 45 or 50 degrees, that's when we start talking about surgery. And surgery is not mandatory the moment you hit 45 degrees, but that's sort of the moment that we begin that conversation. And the reason is because curves that are over 45 to 55 degrees tend to progress even later on in life and be the ones that cause problems. And then another thing to mention is physical therapy. So I mentioned brace treatment. Physical therapy, as far as we understand it, for the most part, there's not a clearly established window for when it can be useful. So we can use it at any point in the spectrum. It can be used in a patient with very mild scoliosis who's concerned about posture. We can use it in a patient that is in that bracing window to be synergistic with bracing. And we can use it after the patient's reached skeletal maturity and they're no longer indicated for a brace to help somebody better align their standing posture. So just a word about bracing. Some of you might be very familiar with this if you have kids who have been counseled about bracing or maybe already wearing braces. There's many different kinds of braces on the market, and what you get recommended is often based on the familiarity of the doctor who's prescribing it and where you live. But in general, it's a customized external orthosis, so it presses on the rib cage and presses on the hips. It's worn under the clothes, and the scoliosis curve should look better when it's in the brace. And the main goal is to prevent surgery. The secondary goal is to maybe prevent any progression at all. And then in some patients, we get lucky, and if you have just the right amount of correction in the brace and just the amount of growth remaining, we can actually make the curve a little bit smaller. And in order to work, it has to be worn for a long period of time. That means a long period of time every day, and that means basically throughout the period of rapid growth around adolescence. And our understanding about how much to wear the brace and when brace wear is important comes from a lot of background research, but clearly the most important influential paper about this was a paper published by Stuart Weinstein in the New England Journal of Medicine. And this was a high quality randomized controlled trial where they randomized kids with scoliosis to either wearing a brace or not wearing a brace. And they found that patients who were randomized to wear a brace had a much higher chance of avoiding surgery. And it was so great, the difference, that the National Institutes of Health actually stopped the trial before it was completed because they felt it was unethical to continue because the benefits of bracing were so overwhelming. And then one of the secondary things that they found in this paper was that they tracked the amount of time that kids wore the brace. And they found that when kids were noted to wear a brace more hours per day, they had an increasing chance of success. There was a nice direct relationship that more hours in the brace increase your chance of success. So that affects how we counsel patients. And then a word about physical therapy. So the main type of physical therapy, there's many different kinds of scoliosis specific physical therapy modalities. But the most common one is Schroth. So this was developed in Germany by a lady named Katharina Schroth. And then it's been modified to different schools. But the general idea behind it is a physical therapy program that asymmetrically strengthens your muscles and teaches you body awareness so that you can use your own muscles to correct some of the postural differences that are associated with scoliosis. As I mentioned before, it can be used independently when somebody's not indicated for a brace, or it can be used synergistically with a brace. In my opinion, and in most doctors' opinions, it should not be used as a substitute for bracing because the benefits of bracing have been so clearly established. I would never prescribe therapy alone for a patient who was otherwise indicated for bracing unless there were some really extenuating circumstances. And the evidence base for Schroth and physical therapy in general is growing. Maybe 5-10 years ago, if I were to give a talk like this, I would say, well, the evidence is kind of wishy-washy. But every meeting that we go to of scoliosis professionals, there is more evidence coming out that there does seem to be a clear measurable effect. That, if you do these types of exercises, you can't decrease your curvature. It's probably not as big of an effect of bracing, but it is important. And so it's something that we offer at Stanford and something that I think it's important that families are aware of. And so what happens though if your curve progresses, or maybe you present a little bit later and you're out of the window for these treatments? Well, that's when we discuss surgery. So I'll just give a brief overview of the types of treatments that we offer. So surgical treatment for scoliosis, the gold standard is still a posterior spinal fusion. And a spinal fusion means that we take all of the different motion segments in the spine and we fuse them together surgically. So instead of working like many different bones, it works like one bone. And so our goals, number one, are to get your child through the operation safely. We want to prevent progression later on in life so that we set you on a better trajectory. And we try to obtain as much correction as we can safely to straighten out the curve. And so this is a treatment that's been developed over many years, and it's very safe and very routine in high volume hospitals. Patients usually stay about 3 days in the hospital, sometimes less, occasionally a little bit more. You take a few weeks off of school to recover. You're back to most activities at 6 weeks, and it can vary depending on your surgeon and the type of operation that you have, but you're mostly back to high impact sports with no restrictions, somewhere between 3 and 6 months. The complication rate, thankfully, is very, very low. We take it very seriously. No one wants to sign their child up for something that risks any complications, but there is a complication risk with every surgery, but thankfully with posterior spinal fusion, it's very low. But there are some new treatments that have come onto the market that are important for people, families who have scoliosis, to be aware of. So the US FDA has conditionally approved through something called a humanitarian device exemption 2 different treatments, surgical treatments for scoliosis that do not necessarily involve fusion. First is called anterior vertebral body tethering, which involves approaching the spine through the chest and placing screws sideways. And instead of putting a rigid rod and fusing the spine, we put a flexible rope or a tether in, which asymmetrically limits growth. So as a child continues growing, the scoliosis can straighten out, and in an ideal world, the motion is retained. Another example is something called posterior dynamic distraction, which the FDA approved in the same year under this humanitarian device exemption. And that is a device which we implant through the back, similar to a spinal fusion, but we don't expose the entirety of the spine. And it essentially functions as an internal brace, where we, instead of limiting the growth on the convexity, the outside of a curve, we actually prop up the concavity or the inside of the curve and straighten out the spine after that. And then after that's done, then some patients are having these devices removed and some patients will retain them. Both of these devices are very young, and these techniques are very young compared to a spinal fusion. And so we're still learning about who might benefit from them, and we're better understanding their risk profile in the context of the established treatment of spinal fusion. So for most patients, they're not really the best option, but they might be for some patients. So some families are very interested in learning more about them. So in summary, this is kind of a brief whirlwind tour of scoliosis, but I think it's good even for families that might be signed up for this kind of a webinar, because when I'm taking care of a kid with scoliosis, the way the system works, I have a very brief amount of time to give such a large volume of information to families. So it's good to hear it in a lot of different ways. But in summary, scoliosis is a 3D spinal deformity, even though we measure it in 2 dimensions, commonly presents in adolescence. It does progress in most cases during growth. So that's the window where we have to treat it. Untreated, it's been documented that bigger scoliosis can lead to impaired quality of life in adulthood, but we have great treatments for it now, and early detection improves the success rates of those treatments, especially non-operative treatments. And late detection, or sometimes when a brace or non-operative treatment fails, leads to surgery. And I've given you some examples of some roads to success even through surgery.
Awesome. Thank you so much. That's really, really high yield information, and very clearly explained. So thanks so much. So let me ask, you alluded a little bit at the beginning of your talk to kind of the system issues around scoliosis, and we know it's very complex, again, from getting scoliosis diagnosed to getting in to see a specialist, et cetera, et cetera. So with all the moving parts and, the sometimes burdensome system, and sometimes, many patients we know live far away from the nearest specialist, et cetera. But maybe you can give us an example, having treated hundreds of scoliosis patients, maybe give us an example of a patient you remember that kind of everything fell into place and it just kind of worked perfectly.
Yeah, sure. So I can tell you, I'll give you, we can call this girl Emma. I'm not going to use real names, obviously, for privacy purposes. But so Emma is an example of a kid that I took care of recently, where everything kind of came together how I think it ought to. So she's lucky enough to live in a place where she can see a really experienced pediatrician. So she went to annual pediatrics visits every year, and she was around 10 or 11 years old, and she hadn't really hit her adolescent growth spurt yet. And her doctor did a regular physical exam, noticed a little asymmetry in her spine, and sent her to me. So I got an x-ray at that point, and that demonstrated that she had a curve that was around 22 degrees. So 22 degrees is great, because if you have a lot of growth remaining, that's kind of at the smallest curve that I would ever consider bracing. And if you have a lot of growth remaining, then we have a great opportunity for the brace to really be effective. And so Emma was at this point, right, where she saw me, and it could go either way. Untreated, a 22-degree curve in a girl who's at the beginning of adolescence could definitely turn into a surgical magnitude of curve. But with the right non-operative treatment, we can avoid all that. And so we're able to do that for her. And so we got her into our clinic and gave her a combination of bracing and physical therapy. And so the physical therapy we used to sort of help her be a little bit more posturally aware, stand with more symmetry. And then the bracing, we were able to start a nighttime brace. And I'll sometimes do that for patients who are kind of before the growth spurt, and I think they might not necessarily need the full benefit of all-day bracing. And so we started with a nighttime brace, and then maybe as her growth got a little more rapid, we transitioned her to a full-time brace for a brief period of time, and then back to a nighttime brace. And over time, as she wore the brace, in some cases, and in Emma's case, we actually saw the curve get smaller. And so she actually finished bracing with a curve in the high teens, which is awesome. And so, sometimes it doesn't happen exactly like that. Maybe we start with the 22-degree curve and we end up with the 25-degree curve. But the point is, if we see a patient at that moment, they have the right access to care, we can provide them effective non-operative treatment, and they can avoid the need for surgery.
Awesome. Yeah, those are such great stories when it all just works out kind of as it's supposed to. So, I know you've seen patients over the years where, for a variety of reasons, the system fails patients, to no fault of their own. Do you have any examples that you recall of, patients where things didn't work out as intended?
I do. and many doctors who take care of scoliosis patients have plenty of these. And unfortunately, the pandemic, we saw a lot of this because sometimes many of the systems that people had in place to monitor the health of kids kind of broke down in the pandemic. A lot of pediatrics appointments were done via telehealth, and maybe they couldn't get a great exam. Other times when it happens are maybe somebody who lives in a place where a pediatrician just doesn't have as much experience in scoliosis, or sometimes for one reason or another, it's just challenging and it gets missed. But I can think of an example of a kid. We'll call her Nicole. She, presented to me just last week, and she hadn't had an in-person pediatrics appointment for a while, and basically that happened during her adolescent growth spurt. And maybe in 2019, the last time she saw her pediatrician, everything was fine, but these things happened very quickly. And by the time she presented to me, she already had a 45 or a 50-degree curve, and she was already past the level of skeletal maturity where a brace would really be effective. So the brace, only really works if you capture a kid in this period of rapid growth, so you can guide their growth with the brace. But in her case, the curve was too big, and she didn't really have enough growth remaining. So at that point, we had to have a surgical discussion right when I met the patient, which is always really challenging.
Yeah, interesting. So patients, for one reason or another, come to see you when the disease or the scoliosis is too far progressed for the effective conservative measures. Yeah, interesting. Anything else? Any other kind of examples of kind of care pathway gone wrong?
Yeah, I mean, I think sometimes it's not care pathways gone wrong, but I can tell that the system that I work in, though we're all doing our best, the system sometimes just doesn't provide families with enough support to really navigate and get through this. It can be super overwhelming for families when they hear about a diagnosis of scoliosis. And I know that, unfortunately, when I leave the room, sometimes the families just haven't gotten enough. I mean, they need more information, they need more support. And they just want a little more validation and understanding of what's going on so they can make the best decisions for their kids. I totally understand. I'm a dad, and I would want the same thing for my kids. And so we have, a saying in our practice that we have no problems with second opinions, right? Because if my kid needed surgery, I'd probably seek a second opinion too. But sometimes that's just hard for a family to obtain. And when you go onto the internet, there's just a smorgasbord of different information. It's very hard to evaluate whether the sources you're getting these information for have ulterior motives, or whether they're really giving you the truth. So there's examples of kids that I've seen who maybe have a curve that's not quite in that braceable range, maybe 17, 18 degrees. And I'll explain scoliosis to the family and say, well, but we need to keep monitoring this and come back in 6 months. And it's a very tough 6 months for some families to wait. And I don't think that we need to be x-raying very frequently because I don't want to expose kids to excess radiation. So I think 6 months is a reasonable time for an x-ray, but it would be great to have something to offer those families so that they could keep track of things at home and not feel like they're just kind of forgetting about it. And don't want to be surprised when they come back and see me in 6 months. I'd love to have something more to offer to those people. And then, also maybe a family who's in the bracing window, maybe somebody who's, has a brace, we've been able to get to the brace, but maybe they live far away and there's no physical therapist, there's no, knowledgeable team around them. They're driving, a couple hours to come and see me. It would be wonderful, to have a mechanism for that family to tap into a community of people who knew more about scoliosis and who could help educate them and guide them through the process more than I can when they come and see me every 6 months for our brief appointments.
Awesome. Really helpful. Thanks. So maybe it's probably a pretty good segue to transition to one of the things that excited us about developing as an opportunity to improve care for these patients. And so here at Stanford, we developed and are continuing to develop a technology software that works on a smartphone and captures a patient's three-dimensional contour of their back. As we saw in some of the clinical pictures that Dr. Vorhies showed, the surface of the back and how asymmetric or crooked it is when they bend over or stand up, turns out is pretty closely correlated to their Cobb angle, and it's an indicator of how severe the scoliosis is. So we have developed currently under regulatory approval a method to assess the patient's severity of their scoliosis using a smartphone, done either taken either by a clinician in the office or by a parent at home. We've been developing this for a while. We've done a number of research trials at Stanford with this. So John, thought we could transition out and maybe summarizing some of what you found in your research.
Absolutely. Yeah, I'd love the chance to share it with people. So we get a chance to share our research often, at national meetings for doctors, but it's often tough for families to have access to new developments in the field. So let me show you some of the stuff that we've been doing recently. So I'll start by kind of explaining sort of the standard that led us to understand, to why we wanted to dedicate our time to this. So this is the scoliometer, and so many families on this webinar have probably seen this before. It's a very simple device. It's essentially functions like a carpenter's level. So you have a child bend over who you're evaluating for scoliosis, and you're really looking at a tilt in their rib cage. And so you put this device on, and it has, just a little ball that falls along an arc, and it tells you how many degrees of curvature. Now, this is different from the Cobb angle. It's commonly confused even by some doctors. The angle of the scoliometer is not the same as the Cobb angle, but they're loosely related. And so essentially more tilt in the back when you lean over is more likely that you have scoliosis. But this scoliometer alone, though it's a useful general tool, it has a lot of problems. So in most studies, it's just not super accurate. So 30% false negative rate, 20% false positive rate. And so if this is the only tool that you're using to screen patients, it's going to result in missed scoliosis, and late presenters, and essentially avoidable surgeries. And so if you have somebody who is used to seeing kids with scoliosis, then they'll use maybe the scoliometer, but they'll also use a lot of other things. They'll be able to, look at your child and see, subtle differences in the way their shoulder looks and the shoulder blade and the asymmetries in their back. And a trained observer plus the scoliometer is very good at detecting scoliosis. But the problem is that people who are true experts in scoliosis who see a lot of patients with scoliosis are pretty rare. Most pediatricians, even if they're high volume pediatricians, most patients that they see don't have scoliosis. So it's challenging for them to assess. And so often then what happens is that we get a lot of people who have unnecessary referrals, maybe people who don't have scoliosis who are getting x-rays who might not need them. And then also patients who do have scoliosis are getting missed, and like the example I gave you, get presented a little bit late. And it results in a stressful experience for a lot of families. So here's, an example of a typical kid with scoliosis, just so you can see kind of what I'm talking about in terms of how it affects the chest wall. And, if people on this webinar have kids with scoliosis, you know exactly what I'm talking about. It doesn't always look like this, though. Every curve is a little bit different, and every child is a little bit different. Some kids are heavier, some kids are lighter, slimmer, different body types. All these affect our ability to detect scoliosis. But in general, in this example here, you can see the picture of the girl standing. Her trunk is a little bit shifted to the right. So you can see the center of her rib cage is off to her right, relative to her to the position of her hips. She's got a little bit of asymmetry in her shoulders. Her left shoulder is a little bit higher than her right shoulder. Her shoulder blades are a little bit asymmetrical. You can see the contours of her waistline are a little bit different on either side. And then as she bends over, you can see that her rib cage is rotated. And that's a result of this 3D component of scoliosis. So scoliosis is not just a curvature in the front to back plane. It's actually a rotation of the spine. And in the chest, when the spine rotates, the ribs actually are pushed back on one side, and that's what leads to this asymmetry that we see. And that's kind of the most reliable way to detect idiopathic scoliosis. All those other things are important, but this is sort of what the scoliometer focuses on, albeit a little bit imperfectly. So there are many other ways to evaluate patients for scoliosis. And so one of them is 3D topographical scanning. And so this is kind of what got me and Mike Gardner to work together, was trying to bring this technology into, the 21st century. So 3D scanning has been thought of for decades. So actually my senior partner here at Stanford, who's in his 70s now, he's actually retiring this year, he wrote a paper about this in the 1970s, where we were looking at slit lamps to try to define the topography of the surface of a child's back and then quantify the asymmetry. And it works to detect scoliosis. But unfortunately, even in the ensuing 30-40 years, most of the ways to obtain a good 3D image of the back involve a giant room that's dedicated to it, a lot of expensive equipment, and it just wasn't feasible to disseminate to people. But there's been huge advancements in smartphones in the past 5 years or so, and the quality of the image that we can obtain from a smartphone is much better than it used to be. And so using different sensors and camera advancements in your phone, you can actually create a nice 3D image that we wanted to see if it could be used basically for diagnosis. And so just to be clear here, what we're talking about is a research project. We have submitted this to the FDA for approval, but it's definitely still under consideration. So this we can't make any claims about what this can or can't do yet, but I'd like to share with you some of our initial research because I think it's promising. So our goal was to develop an artificial intelligence aided tool that would take a 3D scan from a phone to help parents and help pediatricians and help doctors like me better quantify the risk that a patient has a scoliosis, and if they do have a scoliosis, how big is that scoliosis? And the goals are to facilitate access to care for people who maybe can't see an expert to diagnose their scoliosis, and also to reduce radiation exposures, maybe decrease the number of x-rays that we have to do to detect scoliosis. So the way it works is there's a data capture mode with the phone. It takes about 90 seconds where you move the smartphone around a child in a couple different positions. And then you get a 3D image, which can then be processed in the cloud using some AI techniques. And then you can get maybe different scores and different data, which can help you quantify the asymmetry in a child's back and relate that to whether or not they have scoliosis. So we've been doing this at Stanford now for several years as a research project. So we've been essentially recruiting patients that came into my clinic and my partner's clinics that some of them had scoliosis, some of them didn't have scoliosis, but they were sent by their pediatricians to be evaluated for scoliosis. And we've been doing scans and then comparing those scans to their x-rays and then also to scoliometer measurements that we took. And so we have hundreds of patients now that are in this group, representing a wide variety of curve magnitudes. Like I said, some people presenting with severe scoliosis, some people without scoliosis at all, and different locations of curves, different body types. And so the first thing we did was we tried to basically make some measurements on these 3D scans and correlate them to measurements that we make on x-rays. So this is an example of 3 measurements, one of trunk shift, coronal balance, how your head lines up with your pelvis, and clavicle angle, a measure of shoulder tilt. And we found that the measurements on the 3D scans were highly correlated to the measurements that we were making on x-rays. And this is some data that I presented at meetings like the Pediatric Orthopaedic Surgery of North America and the upcoming Scoliosis Research Society meeting in Seattle this year. And then what we did was we devised a measurement that was essentially trying to be analogous to the scoliometer measurement, but measured on a 3D model. And that allows us to, when we measure on a 3D model, we can be a little more conscious and careful about how where we decide to make the measurement. Whereas with a scoliometer, you're picking one moment in time and one postural position of the kid. And we found that when we did it on the 3D models, which is this graph on the right, it much better correlated to Cobb angle than the traditional scoliometer measurements. We found this promising. And then we took it a step further, and we tried to use some more complicated methods to basically quantify the asymmetry in 3 dimensions. So not just this one point measurement for the scoliometer or reproducing a radiographic measurement, but trying to use some of those 3D methods, which have been developed for years, but apply them to an image that was obtained through a smartphone. And this is an example that we essentially generate a heat map of where the asymmetry is and come up with a number that defines how asymmetrical the child's back is. And we found that was also highly correlated and could accurately predict whether a child had a curve that was above a threshold for treatment, in one case 20 degrees. So we're hoping that this will be great for patients and for doctors who take care of patients with scoliosis. It'll allow them to assess scoliosis with less risk, more convenience, and more accuracy than we're doing now. We hope it'll be less error prone and more efficient, and just facilitate better care for these kids.
Thanks again, John. Really appreciate it. Really helpful and exciting. I agree. So just want to transition. We have a little bit left and we'll have some time for questions, but maybe click to the next slide. Just want to briefly give an overview of where the National Scoliosis Clinic is right now. We're currently live, but continuing to evolve. And so if you want to take a look at the site and explore the offering right now, you're able to not come in, but you're able to have a visit with one of our scoliosis specialist doctors. They're not orthopedic surgeons, but they are trained as kind of non-operative scoliosis specialists. And so they can answer questions, they can guide treatment based on how severe your scoliosis is or your child's scoliosis is. And so this is available right now. And then coming in the next few weeks, you want to click again, John, we're going to have a much greater, let's see, John, can you there? Yeah. Next few weeks, we're going to have a much more robust offering. In addition to the clinician visits, we'll be offering kind of subscriptions or memberships on a monthly basis, which will offer a host of things. And these include, in addition to consulting with a scoliosis specialist, you'll be able to message your provider back and forth with additional questions that come up. We're working with a number of collaborators like special brace makers or the orthotists who can answer brace specific questions. These will be one-on-one and in an office hours setting. We're also working with a number of Schroth physical therapists who have some customized scoliosis directed yoga programs, Pilates programs, even actual physical therapy programs. And we're working through this now. We'll have a number of educational resources, including this and other webinars. And so again, this will be coming in the next few weeks. The app itself, somebody asked in the Q&A, is it available now? It is available in beta testing mode. It works. Again, we're not selling it or marketing it. We're waiting for FDA approval, but it is available for beta use. So that kind of brings us to the end. We've got a little bit of time for questions. There have been a few good ones in the chat. So John, first, actually a really nice comment. Thank you for the opportunity. This is from a doctor of physical therapy. Thank you for the opportunity to listen to both of you addressing the topic of scoliosis. As a physical therapist, listening to your approach and collaborative work makes my heart sing. I hope in the future you can expand your research to the effects and benefits of fascia release, neurovascular mobilization, and neural tension release to help the system grow and minimize asymmetry, et cetera. So I don't know if you have expertise or thoughts in like specific therapy modalities. I think it's clear to all of us that they are very effective. But yeah, open it.
Yeah, no, it's a super exciting developing field. You know, I think that for a long time, it's been kind of a cottage industry with a lot of different people with a lot of different ideas. But really, in the past few years, a lot of my colleagues have been studying the effects of physical therapy in scoliosis patients very rigorously. So I'm excited to see that emerge over the next few years and be a part of that research as well. At Stanford, we what we offer within our system is the Schroth Barcelona School, which has many different, as I'm sure many of the audience is aware, but many different components of scoliosis specific exercises, and we're looking at that. But I'm also excited to hear about many different modalities. I know so many people are very interested and conscientious about how they take care of kids with scoliosis, and there are a lot of great ideas. I think one of the things to be that I try to do in my practice is be very humble about what I know and what I don't know. I think that there's some things that are facts that are clearly established in medicine, but then there's a lot of things that MDs or nobody really knows specifically about scoliosis. So I'm very open to new ideas and excited about benefits that they might offer to my patients.
Cool. So here's a good one, actually. And I think, this is a great example of a potential benefit of the National Scoliosis Clinic, where people may not have enough time with the surgeon to ask questions like this, but we offer consultations with the brace makers themselves about specific braces. But I'll ask you, since we're here, it's a good question. My daughter had difficulty with her scoliosis brace. I think it was a Boston brace. How do other braces available improve on that, or how are they different or better, et cetera?
Yeah, so there are a lot of brace options now, and the Boston brace is still very, very popular and very common because it works. So that trial that I showed you in the New England Journal of Medicine, most of the patients in that trial had Boston braces, not all, but we're just starting now to understand and get some new data to comparatively analyze braces. It's a challenging thing to study because there are a lot of different factors and a lot of nuances in different types of curves and patient populations. So I think it's gonna be a while before we'll know, if one brace is better than the other, but your kid will know if the brace is right for them or not. And some kids just don't feel comfortable in the first brace that we try. So the Boston brace is a plastic brace that's comes in a combination of customized and prefab components, and so it can be customized with padding. But there are other types of braces that I have tried in patients that have not been happy with the Boston brace that have been successful. So there are, depending on the curve type and the age of your child, there are nighttime bracing options, which are often better tolerated. And then there are also other full-time bracing options, like the Rigo Chenot style braces, which focus on derotation, WCR type braces from the Align Clinic. And then even newer types of braces. There's one on the market called the Whisper brace, which tries to do some correction while also maintaining flexibility. So there are definitely a lot of options. So don't give up if the Boston brace didn't work for you. There's a lot of different directions to go.
Thank you. So maybe I'll just make a comment on, so there's been a few questions here. We've actually had a few questions prior to this as well, about more senior people with scoliosis. So just the bigger picture of scoliosis, there are different types. Adolescent Idiopathic Scoliosis is one type, and John, being a pediatric orthopedic surgeon, focuses his practice on those patients with that diagnosis. More senior tends to be the quote degenerative scoliosis, which forms later in life. So while the National Scoliosis Clinic is ideally designed for some of the issues that affect the adolescent age group around the app with the screening and monitoring through adolescence, et cetera, our scoliosis doctors on the telehealth service do have some expertise in giving advice, and some of the other services that are a component of the membership, such as the therapists and the yoga and the Pilates, will absolutely have the potential to provide benefit to older people with scoliosis. So, I guess go ahead.
No, that's totally true. And I think, it's important to note that, a lot of the things I've talked about focused on children. And I think as, pediatric orthopedic surgeons and scoliosis doctors who primarily take care of children, we can sometimes be super focused on, one goal. and maybe, there's windows of opportunities of treatment, and we're trying to keep kids under this 50-degree mark. But the fact is that scoliosis can affect people in different ways, in different magnitudes throughout the course of their life. And so a lot of these treatments like bracing and surgery have very specific timings and indications in kids, but it's a little different in adults. And it often depends sometimes less on what the x-ray shows and more on how somebody feels. But I think the important thing to note is that a lot of these non-operative treatments, specifically different types of physical therapy, have a lot of different goals. And they're not just focused on decreasing the curvature, but they're also focused on making you just generally healthier. So having better joint mobility, stronger, stand with better balance, feel less pain, breathe more deeply. And all of those things are benefits that can be realized at any different age. So I found, I don't take care of very many adults. I do some, but very many adults with scoliosis in my practice. But I found that physical therapy approaches are super helpful in that population. And I'm excited that we'll be able to offer people a window into learning more about that, because I think that sometimes that can be hard to find in different areas of the country.
Yeah, thanks. All right, here's a great one. One of the impetuses for us kind of starting to develop this technology was around the issue of radiation in the current pathway. There are a number of studies that are a little scary. Like if you've had a full series of scoliosis x-rays through your adolescence, you're at a real increased cancer risk later in life. But the question here is, what do you recommend for families who are seeking to avoid or limit X-ray radiation exposure? So how do you talk to your families about radiation?
Yeah, it's a big deal. And it's something that I talk about with families very frequently. And I want to emphasize that this should really, first and foremost, be, getting an X-ray should be a decision that you make with your doctor who knows your child's specific situation. Because if your doctor feels that your child needs an X-ray, then don't trust some Yahoo on a webinar who doesn't know your kid. But that being said, I can give you a little background into sort of, what I do now and what I'm hoping, in the future for my patients. There have been a lot of studies that look at kids with scoliosis, specifically girls, because idiopathic scoliosis happens much more commonly in girls. And they historically have gotten many different x-rays over the course of their childhood. And this can affect radiosensitive tissue, specifically the thyroid and the breasts, because they're often exposed to radiation during these x-rays. So, I try to limit x-rays and really only get x-rays when I have a decision point. And I'm going to use that x-ray to change, how I take care of the kid. And sometimes we have to get those x-rays. But one of the great advancements that's been made in my time in practice is that in high volume scoliosis centers, we're not using standard x-rays. We're not using the same x-rays that were used 20 or 30 years ago. We have different machines that are able to obtain images with much lower radiation, which confer a much lower risk to patients. So that's one thing to keep in mind. But I also hope that with this type of technology that we develop, if we continue to see positive results and be able to better correlate the measurements that we can take on a 3D scan to the measurements that we know we can get from an x-ray, that I might be in the future able to monitor a patient with scoliosis and track their outcomes with fewer x-rays. And that's definitely a goal of mine.
Awesome. Fantastic. Thank you so much. So I guess just comment on the final question. Will recording be available? Yes, this will be on our website to watch at a later time. So it'll be accessible later. So we're right at time. Thank you all so much for joining us. And Dr. Vorhies, can't thank you enough for taking your time to share your extensive knowledge and wisdom around scoliosis. And we're excited to help patients and families navigate scoliosis in a new way going forward. Clearly, the system that has been in place for the last 40 or 50 years around screening and monitoring, et cetera, needs to change. And so we're excited to do that. And please reach out if you have any questions on the website, and we'll get back to you soon. So thank you all so much.
Thank you.
Bye-bye.